right, we are back to part 2 of skin integrity and wound care. So some factors that influence wound healing can be nutrition. So nutrition can put the client at risk, especially when the albumin is less than 3.2 grams per deciliter, because the albumin, when it's increased, means there's dehydration. Decrease means there's liver dysfunction or liver failure. Reduced albumin not seen in acute liver failure because it takes several weeks of lack of production before the albumin level decreases. Consequently, a pre-albumin that has a half-life of less than 2 days is a more sensitive indicator of recent changes in catabolism, how the proteins are being broken down. This test is used for nutritional assessment as well. So here's the deal. When someone has a wound, they need a balanced diet, and they usually increase their calories to 30 to 35 calories per kilogram, and they increase their protein to 1.25 to 2 grams per kilogram. This is when a nutritionist, a dietitian, is really helpful to figure those out. Because, well, it's just not my expertise, but I do know this: they need good sources of protein. So we're concerned when the albumin is less than 3.2 and the pre-albumin is less than 19. Remember, they're both different measures, gram per deciliter versus milligrams per deciliter. When a person's body weight is decreasing, or has decreased 10 to 20%, because that reflects nutritional status. This is not the best time when you have a wound to be on a big weight loss plan, because it can affect how a person's wound heals. Glucose levels that are outside of normal, greater than 120, we want to keep people in that normal glucose level. And I realize there's the new category of normal and pre-diabetic, but they're not diabetic yet until it's over 120. So this idea of keeping them as normal as possible is really important. Again, this hemoglobin A1C, reflective of the diabetic, you don't want to get over 8. That's starting to mean that they're not managing their blood sugars, which is really going to affect the ability of that wound to heal. Clients need protein, I already mentioned that. They also need vitamin A and vitamin C. Vitamin A synthesizes collagen and capillary wall integrity, and it helps with fibroblast function. So very important. And then vitamin A increases wound healing, liver epithelialization, and wound closure. And it actually can reverse the effects of steroids and delayed wound healing. So those are very important. Zinc also is influential when it comes to wound healing and the proliferation of fibroblasts and tissue. Copper, iron, fluids. I mean, iron, oxygen carrying capacity, fluids, because we don't want that desiccation to be occurring. So keeping people hydrated, keeping that tissue in as good a form as we can. So when those things don't exist, then that client is at risk for the wound to not heal. If we don't see changes in a client's wound measurement in 2 to 3 weeks, then it's considered a non-healing wound. And then other things are put in place to contain drainage and manage a wound that isn't healing. So we want to see that there's changes that have happened in wounds. Other things that can influence wound healing: tissue perfusion, the ability of the capillary bed to get the oxygen to the tissue, which can be compromised when a person is obese because of the excess of fatty tissue. Smoking, I want to pause and hear you think, why is smoking an issue, right? Vasoconstriction, and that prevents the blood from getting to the tissue. Diabetes, you start getting the decreased peripheral vascular perfusion, and that can be a problem. Atherosclerosis and the buildup there. So the tissues need to be well perfused. Infection is an issue when it comes to tissue. wound healing. So wound infection prolongs the inflammatory phase. It delays collagen synthesis. It prevents epithelialization. It increases production of pro-inflammatory cytokines, and it causes more tissue destruction. So 5 things that we can list here that infection influences. So the inflammatory phase, it prolongs. It delays collagen synthesis, prevents epithelialization, increases production of pro-inflammatory cytokines, and more tissue destruction. Now, you notice I bolded out here, drainage does not equal infection. Drainage is part of the inflammatory process, and so drainage can be good as it rinses the wound out and the bacteria's out. So drainage doesn't mean the wound is infected. However, when the wound, it has pus in it, it has purulent fluid, suppuration, and 2 other words that are pus, when there's an increased volume or character of drainage. I mean, a little drainage and then all of a sudden there's a lot and now it smells, or maybe it's thicker, then that can indicate infection. Redness can mean infection. It can also mean inflammation if it's those first 2 or 3 days, but accompanied by fever, pain, odor. This is problematic. This is looking like infection. One of the measures that we look at when we're checking lab values is we're looking at the lymphocyte count. The total lymphocyte count is reflective of the immune system's ability to help the wound heal. So a total lymphocyte count that's greater than 1800 means the immune system is intact. That's a good sign. When the lymphocyte count is between 900 and 1800, the immune system is impaired. When there's less than 900 in the total lymphocyte count, then there's anergy, which is the immune system is ineffective at this point to help this wound heal. So we want to be alert to lab values. So we're looking at the complete blood count so that we can see the white cell count and look at the differential to see what the leukocytes, the neutrophils, the macrophages, we're looking at those measures. We're looking at the lymphocyte count to look at immune system measures to see what is the potential for healing here. Hemoglobin, the iron carrying, oxygen carrying capacity, and iron transferrin. You're looking at hydration, noting that related to the hematocrit, and that's telling us that those cells have fluid in them to help the tissue heal. So lab is important when we're looking at infection and wound management, so keeping an eye on that. Other things that can influence wound healing: age. The very old have a difficult time, maybe an immune system that's not as intact, skin that is not as supple as it used to be, and so there's factors in place that can affect wound healing. Medications people are on can affect wound healing. Cortisone doesn't always help wounds heal, so noting what all they're on. Their in general health status, the comorbidities that they have going on, and the ability to heal a wound. I mean, just take a diabetic, for example. They're at a higher risk for impaired wound healing. And immunosuppression, when the immune system doesn't work, as we've mentioned here, then there's difficulty with wound healing. So we want to keep an eye on the lab value and changes in the lab value. The psychosocial impact of wounds needs to be noted. Body image disturbance. I mean, if those sores were on someone's buttocks, that's a whole different story, right? You can cover that up. It's not comfortable and doesn't make sitting nice, but it's not what people see. But who wants to go out in public looking like that? We're a very self-conscious people in society, and it can be very disturbing. So talking to people and their coping mechanisms, their support systems, what's there to help and to assist with the healing process. What are their social resources when it comes to finances, people, community, and that kind of thing. Even their healthcare resources as well. need to talk to them. So we have all this information now about clients. What do we do? Well, let's put it all together. We're going to start with assessment. We're going to assess skin. We know how to do that. We know to look at skin, but there's more assessments that we can do than just simply, check skin turgor. We're going to notice what we know already: color, temperature, turgor, and integrity. But we also want to assess for risk for pressure injuries. There are a number of different scales that are used to measure. And in the Central Valley, I mostly have seen the Braden scale being used. And what happens is every shift, the nurse rates the client for their risk for getting skin breakdown. On the next slide, we're going to look at the Braden scale, but you can see where the lower the number, the higher the risk in both of these, Norton scale and the Braden scale. So in the Braden scale, depending on which one, but most of the time 23 points possible, possibly 24 depending on the scale. And so if the client has less than 19 to about 15, then there's mild risk. If their score is greater than 19, then they don't have a very high risk of skin breakdown. And you can see if it gets down to 9 and below, then they have a very high risk. What's noteworthy is in your hospitals, there are rubrics that are posted all around that tell us what we're to do. So for example, if their score is, let's say 18, they're a mild risk, then we want to remind them to turn. Right? Keep them hydrated, but they're a mild risk. They're probably mobile. But when they start getting to 10 and 12, then maybe we're making hourly rounds because it's related to incontinence. Now they need a pressure relief device and so forth. When they're at very high risk, now they're on a turning schedule. They're on a pressure relief device. They are being monitored every hour to be clean and dry. There's things that are put in place so that client, we're able to help decrease the risk for the client to get skin breakdown. So that's the significance of that. You want to have nutritional support for your clients. So what is their nutritional status? What is their appetite? Are they anorexic because they're in the hospital? I'm not talking about anorexia nervosa. I'm talking about they're sick and they don't feel like eating. And so they're not eating well. They're not getting in the protein that they would need. You're checking the lab values to see what is their H&H, what is their CBC, their white count, transferrin, their total lymphocyte count, their albumin, pre-albumin, all of those things. How are they doing nutritionally? Looking at that blood glucose for the diabetic, right? And looking at their exposure to body fluids. Are they keeping clean and dry so that maceration, irritation of skin from excrement isn't occurring? And are they in pain? I don't know about you, but when I'm in pain, I don't move around. I curl up in a ball and I just want it to go away. So is pain a factor in people not moving, which puts them at risk? The Braden scale, which is a pressure sore risk assessment scale, looks like this. This particular scale has a maximum of 23 on it, and you can see how they get their score. So the higher the score, the better. So sensory perception, can they respond to pressure? You know, like you and I were sitting in a chair right now listening, and it's like your bottom gets tired and you shift your weight. But do they have some deficit so that they don't respond, they don't move? Maybe they're in a coma, they'd get a 1. They're slightly limited, maybe they're confused and you have to ask them to turn, they get a 3, and so forth. You see moisture, degree to which skin is exposed. So incontinence, are they rarely moist? You and I, we're rarely moist, but someone that is incontinent, they're moist all the time, we have to check them. They have adult briefs on all the time, then that increases their risk. Maybe they're occasionally are moist, maybe once a shift, maybe once a day kind of thing, versus all the time and just constantly. Activity, are they on bed rest. They're bed fast, can't get up and move around, or they can move from bed to chair, so they get a few more points. They get up and walk occasionally, at least they get up and go to the bathroom kind of a thing, or they're up and about, walking the halls, kind of a deal. Mobility, ability to change and control position, like can they turn themselves, or they need assist, reminders, total assist, or completely immobile. Nutrition, you can see we grade them based on usual food intake pattern. Are they eating their meals? A reasonable amount, around 1,600 calories for the average adult. What's going on? And is there a risk for friction and shear? Are they sliding down the beds? Are they scooting up with their elbows? And look at their elbows. Are they sliding down in chairs when they're up? Or do they have good control of their body? So you can see the risk factors are the same here. But on the bottom, I wrote and told you the total points available. So, and again, on this particular brain scale, I copied it, had the stages. So that's what a brain scale looks like. Again, it's on every chart. And just because the last shift made a score of something doesn't mean that's the score you're going to put on. You're going to evaluate them based on your findings. So if they have a urinary catheter, they were moist all the time, but they put in a urinary catheter, and now they're only moist with the bowel movement once a day, then they're occasionally moist where they were constantly moist. See, things change from shift to shift. So it's based on what you find on your shift. Don't just copy. That's just lame, to be perfectly honest. All right, there's other kinds of wounds besides just pressure wounds and surgical wounds. I think this might have been in your flipped classroom. Let me see, well, maybe not. Wounds in an emergency setting could be abrasions. Abrasions don't have internal bleeding, they're superficial, so scrapes. Lacerations, cuts, and bleeding can occur with those. Punctures can be things like a nail, a knife, and those could have internal bleeding, so we want to make sure to allow that puncture wound to bleed and remove debris and dirt that could contaminate it as well. But when it comes to first aid of these emergency type wounds, you want to ask them about their last tetanus shot, and if they haven't had it in the last 5 years, it may be necessary. So want to be conscious of that for clients. Bleeding wounds need to be covered with sterile dressings, and if and when they're saturated, apply a second dressing on top, because if you remove the first dressing, it may disturb the blood clot that's formed. So we usually just kind of pile them up in the beginning and then change them on a little more regular basis. We want to note the appearance of the wound, the amount of bleeding, and so we're talking in number of dressings that are saturated, how much they're saturated, and in what time, amount of time it took to saturate the wound, and size of wounds. So measuring them certainly on admission. We know how to measure wounds, length by width by depth. Excuse me. Note the healing of the wound, and be sure and note what's the peri-wound around the wound. Note the character of exudate, and I know that that's been talked about much, so what does it look like? And serous and serosanguinous, or serous is going to be clear, sanguinous red, and then of course serosanguinous would be pinkish, purosanguinous would be opaque, pinkish reddish. But purulent drainage can be all sorts of colors, so that's where we can get into the greens and the tans and such. So color doesn't necessarily mean infected, especially yellow. Serous can get mixed up with yellow type drainage, but purulent drainage that's opaque and green, it's not looking good, right? So that's where it can be colorful. In the picture we have here, you have a surgical primary intention healing wound, right? It is held together. The wound edges are well approximated, secured with staples is how it would be documented. And there's a 4x4 dressing over the Jackson Pratt drain. So that's a bulb that's compressed and then the plug is closed, so that the bulb, it's trying to open up. So that's putting this mild pressure to draw out the blood that may be underneath the wound, deep in the wound. The surgeon puts that in, anticipating drainage and wanting that drainage to be removed, because if the drainage stayed underneath the wound edges, the incision edges, it could cause a hematoma, and that could cause pressure and damage to the tissue, but it can also split the wound edge. It can split that incision, cause some dehiscence. So the point of that wound, that drain, is to help pull off the drainage. To empty that bulb, you're going to, you can't really see my finger, but you can see me looking to point. That little tab right there above her index finger opens. When you do that, make sure you've got gloves on like her, and you stand back and hold on to the bulb, so that when you open that little top, the bulb will just open up and it can spit a little, so you don't want to get blood on you. Once it's open, then you turn it over and you squeeze that blood out into a medicine cup or a little specimen container cup, something that you can measure the volume with. So the purpose of drains is to pull off excess drainage that could potentially build up under the wound itself. I'll show you a couple other drains as we go along. All right, so more wound closures. Staples, that's this wound, and that one looks pretty fresh because it looks reddish, so we're seeing some inflammation there. Sutures, stitches, we took those out in the skills lab, or adhesives. So you want to make sure and palpate the wound for tenderness and make sure that no oozing comes out of that wound. And then culture the wound. There's aerobic and anaerobic specimens. Talk some about this in skills lab. Aerobic is surface type specimens, or bacteria, or I don't want to say bacteria, I want to say microorganisms that would be on tissue, or anaerobic specimens without air, and those would be deep into the crevices of the body where air couldn't get to them. So you can appreciate that most of the time we're getting aerobic type specimens. And when we do a wound culture, your book is fabulous. If you go back to the part at the end of the book where they talk about the skills and how to do a wound culture, it's perfect. So briefly, just note this, that we clean the wound with some solution, typically normal saline, but something that's not an antimicrobial, because you don't want something on the surface of the skin that's going to then get into our specimen and kill whatever microorganisms are there, so we don't get the culture. So you want to just clean the skin off with the normal saline type cleanser, and then you're going to get your culture swab, like it looks like an applicator tip swab, and you're going to press it into a clean area of the wound and just press it down and spin it around in that same area so that you can get some wound drainage onto your applicator stick, but just from that clean area. We don't do like the Petri dish swabbing anymore. Do you remember how you did your Petri dish and go whoo, 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 whoo across the top? Because you can touch the wound edges, and that can, theoretically, it could contaminate the specimen. What we want to know is what's growing in the specimen. And to be perfectly honest, we don't culture a lot of wounds. And one of the reasons is when we culture wounds, they all have bacteria in them. So for a wound to be considered positive, when it comes to culturing, and I think I have this on another slide, we have to have, oh, and I forget the number now, so hopefully it's on my other slide and I'll see it. It has to be like over 1,000, I think it's 100,000, 100,000 count for the microorganism for it to be considered infected, because we all have microorganisms in. So we don't do a lot. The best way to get a good wound culture is to do a punch biopsy and to get a little biopsy of the tissue itself, and nurses don't do that. So they would have to look at the tissue to get a good wound culture. But at least know the difference between the two. All right. Some nursing diagnosis. Once we've done this assessment of our client, what are things that we would, how would we diagnose this client? Well, they could be at risk for infection. That makes sense. Imbalanced nutrition, less than body requirements. They don't have the nutritional support for wound healing. Maybe they have acute or chronic pain. So either one of those is a diagnosis. We have two diagnoses that we can choose from: impaired skin integrity versus impaired tissue integrity. So just by the words, you can tell the difference. We're looking at kind of stage 1, 2 type wounds with the skin integrity. And when it comes to tissue integrity, we're looking at full thickness skin loss below the skin for tissue integrity that's been impaired. So typically on a surgical wound, it's tissue integrity, right? Because they've had to go into below the fat into whatever organ or tissue area that was treated. Once the diagnosis has been picked, let's say ours was impaired tissue integrity, then a goal would be improved tissue integrity as evidenced by wound decrease in size by 2 millimeters within 2 weeks. Man, is that just measurable? Yes. How about this? They're at risk for skin breakdown, and our goal is no further skin breakdown throughout hospital stay, or no skin breakdown throughout hospital stay. That's our goal, which is why we're going to have our turning schedule and so on. Maybe our goal, if their nutrition less than body requirements, is increase caloric intake by 10%. I don't know what that means. 1,800 calories per day in 48 hours. So clear and measurable in relationship to what's going on with that client. Setting priorities and then establishing some continuity of care. Some things that we will do to promote health, our implementations, the things we want to get down to. First, you're going to keep assessing them, right? You got to assess to see how they're doing. So do your assessments, and then we want to prevent pressure ulcers, pressure injuries, which is the better term. Good skin care, keeping the skin clean and dry. And I don't mean dry the skin out. I mean keep incontinence off, keep drainage off, keep their skin in good condition. Put lotion on dry areas as appropriate, but good skin care, good monitoring. You want to position the head of the bed less than 30 degrees because that keeps the pressure off of their ischial tuberosities, right? You don't want them sitting hard on their bottom all day long. So lower the head of the bed when possible. Make sure they're on a turning schedule, and turning schedules get posted in the room so it can get marked. They get noted in the chart so we know how often that client was turned. You know, we've talked about it, that the maximum amount of time that we want a client to be in one position is 2 hours. But that doesn't mean you can't have a turning schedule of every hour. If you start finding every hour and a half, whatever's appropriate. If when you turn, they have reactive hyperemia, well, maybe they need to be turned a little more frequently, especially if they're high risk. So take note of that. That's your job to assess. You want to use appropriate support surfaces, pressure reducing and pressure relieving type surfaces. Pressure reducing are like using foam mattresses. They're reducing some pressure, but honestly not enough. I read somewhere that one foam mattress, like an egg crate or just a foam, only reduces the pressure to about 8 millimeters mercury. Well, that's just not enough. Because 16 to 32, so you have to actually get 2 mattresses to decrease that pressure by about 16 or so. So they don't get rid of it, whereas the pressure relief mattresses actually relieve pressure by having, you can see there'll be baffles like in the air mattress. You guys have all blown up an air mattress and you've seen those long coils that go down an air mattress and you blow it up and then you lay on it. They're just kind of weird when you're laying on it. But what happens in a pressure relief mattress is there's all those coils going down the mattress, and what they do is they're on a pump machine, and the pump will release the pressure in one of the coils. So at that point, the client's laying on the 3 or 4 other coils to the other side, and there's relief, no pressure right there. But then that one fills up, and bam, this one goes down. And so they're supported by those external, or the other baffles around the coil that's going up and down for them to relieve pressure. So it's something that pressure relief mattresses relieve pressure, that the pressure is off, and that's really key. And they can be as simple as an overlay type of a mattress, or they can be as sophisticated and expensive as like a Kinetron bed. Maybe you've heard of that, that just, it's a flotation mattress where they're just on air. They're kind of floating on these beads, and there's no pressure. They're absolutely amazing and very expensive, but can be very sophisticated out there. You want to manage pressure ulcers and wounds by measuring them, noting their location, stage, size, tissue type, exudate, surrounding skin. Now, if you saw that wound, would you just be going, oh, I don't even know where to start? Me either. That's a big wound. So what's really key to this wound is the picture, number 1. Number 2, it's a lousy picture because what's missing? I know, I heard you say it. A measuring device. So a picture is great. If this is 12 o'clock over here on the left-hand side, it looks like, man, it looks like deep tissue damage, right? That maroon dark color in this upper third. The bottom 2/3 is non-viable tissue slough. It looks like yellow slough, yellow and white slough. Looks like they have necrotic edges, black edges. The skin around the wound is pink and maroon. So again, some deep tissue damage. I would venture to say that up there at the top edge, which would be 3 o'clock, if the left edge was 12 o'clock, it looks like there's a tunnel possibly there. I don't know what's going on this bottom edge. So, ooh, boy, that's a mess, right? So take a picture. That's very, very helpful with a wound, and that wound needs some cleaning and some debridement. So we'll talk a little bit about that. To manage wounds, to prevent and manage infection is really critical. So some things that we do to prevent and manage is to cleanse the wound as appropriate. And when we do, there's a basic rule in wound care as to the products we use, and that is you wouldn't put anything in a wound that you wouldn't put in your eye. Well, I wouldn't put a lot in my eye, so normal saline is our product of choice, right? Some wounds can use tap water, maybe some of the superficial wounds, but those deep pressure sores and such, that they need to be cleansed with normal saline. There are also commercial cleansers that are out there, and one of those products is a CHG product, a 5% solution of chlorhexidine gluconate, or by brand name called Iricept. It's the first product that was actually approved by the FDA for wound debridement and cleansing that contains a antimicrobial in it. But when the antimicrobial is used in a dilution of just 5%, they found that it didn't harm the tissues. It didn't become cytotoxic to the cells and prevent wound healing. What they found was it was an antimicrobial that had persistent activity, so it fought wound infection. It bound to the protein in the skin, and it became available for residual activity. It doesn't result in tissue injury. It doesn't delay healing. It appears to have good bactericidal effects, and it inhibits regrowth of microorganisms. A couple other things that it does is it has an antifungal and antiviral effect as well. It seems to be inactive against bacterial spores. So when we talk C. diff, not so great for that at that dilution. All right, but you don't have to freak out if they say, oh, we're cleansing it with that, and go, oh no, that's cytotoxic, we can't use it. No, that one is okay. Other commercial cleansers will say what's in them, and they're usually some form of antimicrobial or just plain saline solution. And you can see those squirt bottles below. They have a sprayer with which you can spray, and the pounds per square inch on those is usually around 8. So you can look on the bottle to see what is the pressure that's being exerted when that's squeezed on or squirted on to clean that wound. We want to avoid cytotoxic solutions. So break it down, right? Cyto, cell, toxic. Solutions that are toxic to the cells of the wound that are going to damage fibroblasts, or are going to prevent that wound from healing. Here are 4 solutions that we want to be alert to. Acetic acid is actually another nice word for vinegar. Providone iodine is an iodine type solution. H2O2 hydrogen peroxide. And Dakin's solution is a brand name for chlorine-based solutions. So all of those have an antimicrobial purpose, and if they need to be used, and sometimes they do need to be used because the wound is infected, and the physician will order, the healthcare provider will order that a wound is cleaned with these solutions, it is recommended that we use them at a half strength at least, so that they're not damaging to the cells. In addition, when these products are being utilized, they're only recommended to be used for a couple weeks. So somebody's got to be keeping track of how long have we been cleaning this wound with this, because what happens is this causes the wound to be clean and helps prevent the infection, but it also prevents the wound from healing. So you have a very clean, non-healing wound if we don't change the wound cleansing product to normal saline or this 5% CHG or by brand name Irricept. So be alert to that. And you'll know, sometimes I'll walk by a room and I'll go, I smell chlorine, like it smells like a pool. And you're like, oh, someone's got the Dakin's going, right? So what kind of pathogen being used for that and such. So take note of that when we're doing wounds. We've talked about how wounds have non-viable tissue, like the slough and the necrotic tissue, the eschar. That tissue has to be removed for the wound to heal. There are ways of debriding the wound or getting rid of this non-viable tissue, and we can do it through mechanical means, which can be using like a water pick. Some irrigation means that has a pressure of greater than 15 psi. I mentioned when we were doing our wound care, cleansing a wound, we cleansed our wound in the skills lab with our 60 milliliter catheter tip, plunger type syringe, piston syringe, and that has a pressure of 4 psi. The wound care experts have, and there's a bunch of them, but in particular, the National, I have to always get this out, National Pressure Ulcer Advisory Panel, the NPUAP, recommends that we use a pressure between 4 and 15 psi as to not damage the tissue. So what are things that would mechanically help get rid of that? Well, that's pressures greater than 15, which is like a water pick or a whirlpool on a wound. Another thing that is not recommended so much anymore, which I've done over the years, and that's to put a gauze dressing into a wound, and you let the gauze dressing dry out, so then it sticks to the tissue, and then you pull it out, hoping that it'll pull out the dry or the dead non-viable tissue. So that's a moist to dry dressing, damp to dry dressing, and yeah. The problem with that is, and the rule that we have or guideline is, that if greater than 50% of the wound base is granulation tissue, that this is not recommended, because the dried gauze doesn't know what tissue it's pulling. It will pull all tissue. So if the wound bed is like lots of more than 50% of non-viable tissue, then that still may be ordered. But that's our guideline. when we're utilizing it. Yes, it's painful, and yes, you want to medicate your client before you go ripping their tissue out of their wound. So that's a mechanical type debridement. Autolytic debridement is when the dressing itself traps in the person's own drainage and their own cells and enzymes, or hopefully will eat away that dead tissue. And so we can do that with a transparent dressing, and it's a great dressing to put over a wound that's got some tissue that's not viable, and then it catches the drainage in that dressing. Think of that clear, that you put on your skin, that Tegaderm that you peeled off. If you put that over a wound and then the dressing makes like a blister, and that drainage that's in that blister is eating away the dead tissue. That hydrocolloid dressing, and I'll show you some pictures later, can work the same way, but it's somebody else's, it's their own fluids is eating away the tissue. Chemical or enzymatic debridement is when we have a cream or ointment or some kind of product that you put on the dead tissue to help, again, eat away that tissue. Often when there's eschar, there's non-viable tissue, that tissue needs to be scored with a scalpel of some sort or something, so that the tissue is broken up a little, so that that enzymatic treatment can get into the dead non-viable tissue and help eat that away. Again, with the enzymatics, there needs to be more than 50% of the wound bed, because that enzymatic, that chemical can get onto good tissue as well. So they're interesting to use. Elase is a product I've used for clients. You don't have to put tons on, because what's touching the non-viable tissue is what's doing work, but you need to get it onto that non-viable tissue cover. Sharp or surgical removal is when scissors or scalpels are used. Wound care nurses that are certified can pull up tissue, that stringy tissue, and cut off the stringiness, but they don't get a scalpel and cut away from the muscle. That's not, they're not trained to do that. That would have to be some kind of surgical procedure that gets a scalpel out to get rid of it. Your book talked about those quite nicely, but what they didn't talk about much was biological debridement. And when we start talking about biological debridement, we're talking about maggots and leeches. And I know, that's kind of how I feel about them too. I can just see your faces, because I can see you. I can see you sitting out there. So here's what's happened with the maggots and the leeches. Leeches bite and suck blood from an area, and they leave behind an anticoagulating chemical that produces bleeding. It also serves as a local anesthetic and acts as a local vasodilator with some antibiotic properties. Those actions of these leeches reduce the venous congestion in areas that you don't want to be compressed. Say a patient had a neck surgery and is developing pressure on the jugular vein. You would place leeches where the congestion is occurring, which may be on the more vascular side of the surgical site, or in the or on the gravity side. So that therapy might be used for plastic surgeons, because they don't want swelling in that area that they've worked on. So yeah, there are a number of specialty surgeons who find leeches extremely effective for patients who have had head and neck procedures, finger reattachments, flaps, or grafts. The leech removes a little bit of the blood that's compressing the site, and then there's oozing, so that those significant amount of blood don't build up over the next 10 to 12 hours. Now, that's leeches. Maggots, for maggot debridement therapy, is approved for chronic non-healing wounds with necrotic tissue, such as pressure ulcers, diabetic foot ulcers, venous stasis ulcers, post-surgical wounds, and traumatic wounds. So for complicated surgeries, maggot larvae secrete digestive enzymes into the wound bed and then crawl around the wound to locate nutrients in dissolving tissue. Within 5 minutes after maggots are removed, patients say things feel better. I know. So here's the truth of it. I've never done this before, and hopefully wouldn't have to. I would think a wound specialist would want to. These are harvested maggots and leeches, so it's not like they're going out in the dirt and digging them up. But they are utilized. There are some side effects and contraindications to maggots and leeches. So while there's no reports of allergies to maggots, there is side effects. It's theoretically possible that maggots could dissolve a partially necrotic arterial wall, leading the thin vessel to rupture under its own pressure. So that could be a problem. And contraindications to maggots could be if they're clearing a methicillin-resistant Staph aureus, so they're contraindicated for a wound that's contaminated with MRSA. The larvae don't seem to be effective in wounds that are colonized or infected with Pseudomonas either. So they're not perfect, but they are an option that can be effective. All right, so need to manage exudate. Exudate needs to be contained. We talked about that with our wound we did. That's why we packed the wound and then folded those 4x4s to keep the exudate within the wound bed itself, and then keep it off of the skin around the wound because we don't want to have a breakdown of that tissue. All right, we want to protect the wound. And often that's what a dressing is there for, to protect it from contamination, from injury, from rubbing. Sometimes we put dressings on just to keep pants or undergarments from rubbing against at-risk area or a tender area. You want to educate the client as to good clean technique, in some cases sterile, but mostly clean technique, and no touch technique of dressings to prevent infection, products to use, how often to do their dressings. You want to make sure there's good nutritional support. I mentioned this on a previous slide. So looking at their intake and calorie count. Put them on I-know, very important. When wounds are bleeding, we want to control that bleeding. So thinking of pressure and pressure points to prevent hemorrhage for wounds. Talked about cleansing the wounds and appropriate products. Sometimes we apply topical growth factors to help enhance that wound environment when the fibroblasts or the tissue isn't able to keep up with the need. And then protecting the skin and tissue from further injury. Dressings. Oh goodness, there's just so many dressings. I went over this briefly in skills. I gave you that diagram or rubric as to what dressing's appropriate for which stage of the wound, but basically consider this. We want to protect the wounds. We want to create a moist environment to enhance wound healing. We need to protect the skin around the wound, keeping that dry, and keeping the wound bed moist. So let's look at some of these products. Gauze, we're going to start from the top left there, and then we'll go right to left. The gauze is a cheap, good product, but it requires a lot of maintenance when people are using gauze dressings. They have to be changed usually every 8 to 12 and never more than 24 hours because those dressings can absorb drainage and become a medium for microorganisms to grow, and so they need to be changed frequently. The hydrocolloid dressing that's on the second row is a nice dressing that that lays on top of the wound. It's a gel product, a hydrocolloid, a colloid type product that actually, when the warmth of the body is in touch with that dressing, it softens up and then fills that space to keep that wound bed moist. whereas the part with the adhesive, it's all got adhesive, and that's the crazy thing. The adhesive will stick to the dry skin, and then the drainage will activate the other part of the dressing to increase the wound healing. Very fascinating. So they're a nice dressing. The transparent dressing is not a great dressing for a stage, sometimes a stage 2 okay, but not a stage 3 or 4 because it doesn't provide a moist environment for that wound. But sometimes transparent dressings are used as the adhesive or the tape to hold the dressing on. The gel, which is row 3 there, is a product that's used for a dry wound. So they might ask for a wound gel to be applied to keep that wound bed moist, and then covered with a Telfa or a non-stick type dressing, you know, that kind of product that's on a Band-Aid that keeps it from sticking. So Telfa or a non-adherent dressing, and then that's covered with that Tegaderm type dressing. The calcium alginate, that's a coil of it there at the bottom of the page. Those are for draining wounds, typically used to fill in the spaces of a stage 3 and a 4 type wound. They are to absorb drainage. They are an alginate made from algae, and so consequently they turn different colors when they're used, so they can turn kind of green or brown or yellow-green, and that's great. That means it's been activated. We don't wet calcium alginate dressings. They need to be used in a wound that is draining, and it's the drainage that activates the calcium alginate. So those are just a few to get going. There's so many, and I know Miss Florence went over a whole bunch of them. There's silver impregnated dressings. There's beads and pastes and things. There's hydrocolloid paste that you can squeeze into the different crevices of a wound to fill those cavities up. So there's all kinds of dressings out there that can be used. Mepilex, they're kind of a mixture of a colloid product. So all kinds that are out there. When you're using the hydrocolloids, the Mepilex type products, those are supposed to stay on 5 to 7 days. And can I just tell you, they're not supposed to be peeled up, and you're not supposed to peek under them to see how they're doing. They're just on there for that period of time until drainage leaks out or the client wears it off for some reason. The alginates are changed a little more frequently because they need to be irrigated out of the wound. So those are often changed every 12 to 24 hours. They absorb and such. When you're using an alginate or a hydrocolloid, we don't really describe the drainage color because they take on the color of the dressing. And so we just don't describe it. And it's understood. So don't feel like, oh no, they're going to think I didn't do my job. No, you're doing your job just fine because we can't describe it. So keep that rubric with you as just some ideas of what's out there and what can we use to change wounds or to care for wounds. All right. You have your paper out that we worked on originally. We're kind of getting towards the end of our information. And so my question to you is, what if your client was admitted with this wound? What assessments need to be done and which dressing would you choose? So right now I have this wound that's up here, but I want you to look at all 4 of those wounds, and the what next is, if they're admitted with that wound, what do you do? What assessments? And what are you going to cover that thing with? Or what are you going to suggest to the doctor, all right, that you cover that dressing with? All right, so you can pause the video right now if you want and work on those. And then, so you can do that. And then the next slide is if that's the what if, then the what next is, after you've taken care of the basics, you've assessed the client, you've got a dressing on, what other treatments do you need to consider? What education does that client need? What referrals might be indicated for each of those different stages? Okay, so work through your diagram on that, and then we'll get to the what then in just a moment, but think about what you would do for that wound. So pause and work on that for a bit. All right, when it comes to changing dressings and reinforcing dressings, there's some basic guidelines for us, and that basically what we want to do is reinforce dressings, especially first surgical dressings. They were put on in a sterile environment, and typically the surgeon likes to take that dressing off on the following day or second day, whatever their plan is. So if there's bleeding, we cover it with another dressing. Part of the thinking is we don't want to remove any clotting that is happening, and again, it's that environment that wound is in. But if there's getting to be a lot of drainage, the physician, the surgeon needs to know, because maybe there's a bleeder, and that needs to be attended to, and maybe they want that dressing changed. So we need to note that. We've packed a wound in the skills lab, so you know how to pack a wound. But here's a different kind of wound that I wanted to show you, and that is a wound vac. Again, I know Ms. Florence went over this for us, but the purpose of the wound vac is to increase circulation in that wound by drawing, putting that negative pressure on the wound bed area. But it also, because that's a sponge that's in there, creates a moist environment for the wound. So you're kind of getting two things to bang for your buck. But you can see on the left picture, that is a sponge that got put into that wound, and then the suction device is put on top of the sponge. And then a transparent dressing is put over the suction piece that you see there and creates an occlusive dressing. Because when you turn the machine on, which is at a very low pressure, somewhere between 15 to 30, I think, milligrams of mercury, it's very light pressure to draw on that wound. And you can see the tubing, and that tubing then will have drainage coming through it. Often bloody drainage that's collected into the suction machine. There's a canister there that collects the drainage, and then we just change that apparatus out as it fills. When those are first applied, patients often like to be medicated because that suctioning, that drawing is kind of painful. At least most report that, and then they kind of settle out and they seem to be stable with it. But this can increase the healing time by months and months. Can you imagine that wound? If it was just left to its own devices, it could be a year or two before that heals. And now, if they have good nutritional status and their blood, levels are good and things are in good place, that could heal up in 3 months. I mean, that's significantly better. So they can't be used on everything. They're contraindicated when someone has osteomyelitis, for example, bone infection, or you couldn't put it on an eye socket, and suck out your brain. So they're not indicated for everyone, but you can see in these circumstances where there's tissue over bone, this leg or the buttocks area, that it's a good option for the client. So wound vac. All right, securing dressings. This dressing on the left is secured with paper tape, and that's an occlusive dressing. So what that means is all the edges have been covered to prevent leakage, whereas if it was open and you just put a couple of strips of tape across it, then that wouldn't be occlusive. Tape comes in all sizes. You can see down there from 1/4 of an inch to up to 4 inches of tape. Paper tape is typically used for wounds to hold dressings on because it's most of the time not as hard on the tissue, but again, it depends on the client. It can be irritating. Some clients have adhesive allergies, and when you take the tape off, you see blistering underneath, and so then we have to get creative as to how to hold dressings on related to allergy, but there's all kinds of different adhesives to be used. When someone has the Montgomery straps, you can see a little bit different style of Montgomery strap in that other picture. It's really best if you prep the skin. And what I mean by that is if you're the one to put the Montgomery straps on, you want to clean the skin and then put like that white, that plastic non-sting barrier that you put on your skin. That's a great thing to put on the skin so that the tape doesn't irritate the skin as well. And you also could put on the hydrocolloid down because that wouldn't be irritating to the skin typically, and then the Montgomery strap would go over that dressing to help protect the skin. So some kind of barrier is really important. You can see some other dressing types down here, these Band-Aid types that come with the tape already on them, and so those can be nice as well. So it's kind of like what's available and what's the best indication for the client. Heel wound, we like to put some kind of dressing on and then use the figure 8 dressing to hold it on, and that way you don't have to put any tape to the skin. So sometimes those spiral dressings or figure 8s can be really helpful for holding dressings on. When you do a dressing change, this should not be new information. Administer analgesics as needed, explain what you're going to do, gather up necessary supplies, should have said, and plus some, right? So check the room, see what's there, and always make sure you have extra. Prepare your sterile field as indicated, and I have to say this and make sure that you appreciate that wound care is usually not a sterile procedure because it's the skin and it's outside and so forth. But here's the problem. In the hospital, wound infections is the second most common healthcare associated infection. We know that urinary catheters are the first. They're working on that. Maybe that stat will change someday. But wound infection is big. So in the hospital, I do sterile technique because I don't want to be introducing anything new in that contaminated environment, right? It's not their normal flora. In their own home, they change their own dressings. They need to be clean, and that's usually appropriate for a wound. Remove the dressings, assess the drainage, the area, provide whatever care needs to be done, and answer questions as needed for the client. When we cleanse wounds and drain sites, we're irrigating, and I told you earlier that we want a PSI that's less than 15 and greater than 4, and we know how to get a 4, but how do you get those others, those greater thans? Well, to get an 8 PSI, you would take a 35 milliliter syringe, that's what we're looking at in the picture, and you would attach a 19 gauge catheter tip. And what that is an IV insertion catheter, and they took the stylet out of it. I'm talking Greek to you. I wish I was in the lecture room where I could show you that and take the stylet out for you. But it leaves behind that soft catheter. So that 19 gauge plus the 35 milliliter syringe, if you drop the normal saline, then you'll be squirting on a little more pressure. Why would we want more pressure? To get rid of wound debris, you know, dried up drainage. We all slough cells, so to get a cleaner wound, sometimes we just need a little more pressure than that little 4 PSI that we are able to get fairly easily. So I just wanted you to see what that was and how to get it. Sutures and staples I went over in the skills lab. Those are the cleaning patterns that I mentioned to you. Every time you go down a different pattern, you have to use a different gauze to clean. So clean the area first, get those crusties off of those insertion sites. They tend to drain a little serous sanguineous or serous drainage, so clean those up. Then put some adhesive on, like a tincture of benzoin, like where the 3 and the 2 are on the right side picture. So put a little something that'll help those steri-strips stick a little, and then apply the steri-strips after those have been, the sutures or staples have been removed. Steri-strips stay on until they fall off. That's what you tell clients. They don't peel them off after 5 days. They stay on until they fall off. If they start to get kind of ratty and they're peeling up, they can trim them, but leave them on. That just gives that wound a little extra support. Wound adhesive works the same way. You don't pluck it off or peel it off. It just stays on till it comes off, and that's how it rolls. The drainage evacuation I showed you on that one picture of Jackson Pratt, this is a Hemovac, and it works by being squished down, and then the seal gets put on it, and so you'll see those when you're in the healthcare areas, maybe if we ever get to go. But those help, again, remove that drainage that would potentially pull up in the wound and cause a hematoma. Keep your clients comfortable positions, and medicate as needed. Good, comfortable linen. We talked about pain. Put those comfort measures into play when wounds are involved. Other things that can help us stabilize a bandage is netting. So you can see on a wound there, they could put that netting to hold it on, so that works nice. Sometimes you've seen maybe wraps around. Make sure and look at underlying skin, and that there's not pressure sores aren't being created by the rims of dressings. Check the condition of dressings, look at the skin and areas distal and proximal to those dressings, and make sure we're not cutting off circulation like that elbow. Make sure it's not too tight, and that we're using our appropriate techniques. There's a lot of stuff out there to help us secure. So when you're not sure what to do, ask somebody. Hot and cold treatments. We did some cold treatment in the skills lab, but make sure that when you're using hot and cold, that the client's able to tolerate it. You want to be careful with your diabetics because they may have neuropathies and may not be able to feel. And so we don't want to burn skin and tissue. Make sure that you understand the purpose of your heat versus cold. When we're using heat, its purpose is to increase circulation, right? It's going to dilate vessels. And so that's the purpose of that. Whereas cold is used to constrict, help reduce swelling. So the local effects of the heat and the cold are important to recognize, the skin irritation. So when we talk about the use of heat and cold, know that we usually don't use heat or cold more than about 20 minutes at a time. Because that's where that's the max of the therapeutic effect. Sometimes 20 to 30 minutes. I mean, it depends on who you read or what they recommend. But if it's used longer than that, you can have a reverse effect after that. It can cause some venous congestion, and you get a rebound effect. And so instead of constricting it, then it dilates. Instead of dilating, it constricts. No, not good. So we want to make sure that those get taken off for intervals of time. Choices of moist or dry heat. Again, it depends on the wound area and what's going on, but make sure when you're using them that there's something against the skin, between the skin. You don't put ice directly on skin. So there's a pillowcase, a piece of cloth, something with that. There's all kinds of ways to put on heat and cold. They have pre-made packages that you activate, chemicals that you activate. There's ice pads that are like heating pads or cooling pads, and so they're putting cold or hot water through those pads themselves, and so wrapping those around the client's whatever extremity, so that aquathermia type pad. Sitz baths are when you put your bottom in just a tub that was meant to soak a bottom or perineal area. So a lot of things that allow us to put some moisture or I mean some heat or some cold onto clients. All right, our final thing, what then? Your what then for your next those four same pictures is, if your client was admitted, and in this case I just put an infected wound on and it appears infected, then what? All right, what are their actions? What assessments would you need to make? Who would you notify? What treatment would you anticipate? Okay, so kind of work through that. Go back to your slides and think about what labs are important. What nutritional information would you need? Who needs to know? Antibiotic treatment, wound care treatments. What are you thinking? What about referrals? Is it time to get that wound care nurse involved again? You know, our intrastomal therapists in there to look at that. Do we need to think systemic? Maybe this is local. Are they at risk for sepsis, right? So kind of just press yourself to look at the bigger picture, and I'll put a little master sheet up in a few days. I want you to work on it before I just give you answers as to things to consider. All right, so work on that. Here's some questions for us. A nurse is caring for a client with edema, which is a predisposition to pressure injury due to edema. So, decreased body utilization of vitamin C. Would that make them get a pressure injury because they have edema? How about maceration of the skin because they have edema? Does that make the skin macerated? I don't really think so. Increased distance between the capillaries and the cells. That makes sense. Increased amount of padding between the skin and the bones. Well, that doesn't make sense. If they're getting more padding, then they shouldn't have a pressure injury, right? Well, that doesn't make sense. So, the best answer, increased distance between the capillaries and the cells. A client has been lying on her back for 2 hours. When the nurse turns her, she notices that the skin over her sacrum is very white. What's another word for that? I can hear you saying it. Blanching. By the time she finishes repositioning her, the spot has turned bright red. The nurse should massage the spot with lotion. Oh goodness, that would be causing more pressure injury, right? Get rid of that. Apply a warm compress for 30 minutes. I never said to do that for a pressure sore. In the beginning, what would that do? That would cause more hyperemia to the area. That doesn't make sense. So get rid of number 2. Return in 30 to 45 minutes to see if the redness has disappeared. Yes, let's see if this is a reactive or an abnormal hyperemia, but we need a little time. So that's good. Let's see. 4, wash the area with soap and water and notify the physician. Not yet. The skin's intact. We need to see what's going on before we go calling that physician. They may need to be called, but not yet. So return in 30 to 45. Which of the following is an example of a wound or injury that heals by secondary intention? All right, so that means we have to know what primary, secondary, and tertiary is. So a burn, that would be an open wound. That's certainly a secondary. Fracture, that's kind of a broken bone and closed. That's not open wound, so no. Sprained ankle, that's kind of like a fracture, so we got 2 of the same thing, so no. A surgical incision, that heals by, I heard you, primary intention. So the best answer we have is a burn. Oh, I know, don't get scared by all the words, but here we go. A patient who has a large abdominal wound suddenly calls out for help because she feels as though something is falling out of her incision. Oh, no. Inspection reveals a gaping open wound with tissue bulging outward. In which order should the nurse perform the following interventions? Arrange from first to last. Are you going to call the physician first? Cover the exposed tissue with normal saline, sterile towels moistened with normal saline first, or are you going to place the patient in the low Fowler's position? We talked about this, so you should easily choose 3, 2, 1 for the order that we're going to buy into. All right, ladies and gentlemen, that is it for wound care. Work on the care plans. Work on those critical thinking sheets. I'll send you some answers in a day or 2. And we'll work on the lungs and heart in another, I'll post those in another day or 2. All right, stay safe. Hopefully I'll see you soon.